Hello and welcome to our podcast, Cozy Conversations with the Sister Project. I'm Lauren. And I'm Michelle. And we're so excited you stopped by for a visit. Come on in. Yeah, make yourself at home. We're two Midwestern sisters who love a good old-fashioned conversation and enjoy sharing our life experiences with one another and you. Consider this your one-stop shop for cozy, mindful well-being, along with some entertainment and lots of wheezy laughing. Oh, you bet there'll be a lot of that going around. Our goal is to live our coziest life and inspire you to do the same because the truth is, we think it's good for your mind and your body. Thank you so much for tuning in. Now, let's get cozy. Well, hello there, everyone, and welcome back to Cozy Conversations with the Sister Project. I'm your host, Lauren, joined by my co-host and sister from the same Mister, Michelle.
Yes, your steady right-hand woman.
You never go away. You never stray.
I never stray. Nor do you. Let's be honest. Nor do you.
Well, why would we stray from one another?
It's true.
Why would we do that? Y'all, we hope you are having a cozy holiday season. You know, today we have a really, really incredible guest joining us today to discuss one of our favorite topics, which happens to be women's mental health. Michelle and I have shared our fair share of struggles with our mental health. For me personally, was postpartum. Michelle, you've shared when, like grieving and during
anxiety,
mom's illness.
Yeah.
Yep. Afterwards. So we really thought it'd be a wonderful idea to join forces with our partner, Meridian Psychiatric Partners, and have a guest from over yonder join us to talk about, an expert to talk about women's mental health. So joining us today is board certified psychiatrist and the medical director of Meridian's Reproductive Psychiatry and Wellness Division, Dr. Aparna Chatterjee. And first, I just want to say the moment I met her, I felt she's super warm and welcoming. And I knew that we were just going to kind of just dive into a bucket of knowledge with
Lauren,
her.
That's what I was going to say. When I met her, I was lucky enough to meet her at like a women's event.
In person.
Yes. And when we got to talking, I'm like, okay, this is a good you are fun. We connected. I'm like, we need to bring this to the platform.
And exceptionally knowledgeable in a area that Michelle and I are exceptionally passionate about, but we don't know all of the things at all. So what Dr. Aparna Chatterjee helped us understand a little bit more about was the mental health and wellness revolving around postpartum, those who are trying to conceive and get pregnant. And then I think the most fascinating part of the conversation was the difference between perimenopause and menopause. Like I learned, my mind was blown.
Head popped off the neck during that convo.
Yeah. So listener, I think that you're really going to get a lot out of this conversation and listen deeply because there's a lot of messaging here. If you are listening to your gut and you're like, you know what, I think it's time for me to explore some ways to, benefit my mental health. I really want you to tune in and hear the messaging here and listen to your own body and mind and see what you're going through. And if there is space for help and if there is need for help. And that's the thing that we always want to encourage people to do here at the Sister Project is to get the help you need.
Like, I just want to say,
there's no freaking point in suffering.
Help and also education. Like, there's so much
Knowledge
that we don't know, as we just said.
So true.
Yeah.
You guys are going to love this conversation. We are exceptionally grateful to the folks over at Meridian Psychiatric Partners and especially Dr. Chatterjee, who you will see us just refer to her as Aparna because that's just how we were introduced to her and whatnot. But she is a wealth of knowledge and we are super grateful that she took the time out of this holiday season to join us on a podcast, especially during a moment in time when we're all really stressed out. We're kind of meeting our threshold or our breaking point. We just want to make sure that you all are taking optimal care of yourselves and your mental health. So please do us a favor, enjoy this conversation, look further into Meridian Psychiatric Partners if need be, and we love y'all and happy holidays.
I have to say, I had an incredible, I went and did a strength class workout this morning.
Yeah.
And that really got me warmed up and ready to go. I already feel the lactic acid setting in. will not be able to walk down the stairs to get the laundry.
Good luck with that. Good luck. Okay.
Oh my God.
So we'll pop in Aparna. Let me just get and if you see me looking over here, this is where my notes are. So apologies for that.
Yeah, she's not checking Instagram.
No, I'm not. That would be extra rude. Okay.
Aparna, are you at home or are you at the office?
I'm home. Yes.
Nice.
Yeah. So no one else is here.
Oh, no one else is there. Okay, cool.
Yeah.
Okay, nice. Well, great. We'll start rolling into this. First, we wanted to thank you, Aparna, for joining us on Cozy Conversations. One of our favorite topics that we love talking about and our listeners love hearing about is women's health, especially mental health, reproductive health, perimenopause, menopause. We don't really know what we're talking about when we're talking about it. I like to find news articles and then regurgitate them for our listeners. So it is a real treat having someone who is actually an expert in the field joining us today. Aparna, thank you for being here. How are you doing today?
I'm great. Excited that it's a Friday. And yeah, I'm really, really honored to be here. You guys have a really cool platform. So
thank you. And thanks for being here. We wanted to kick things off a little bit by learning a little bit more about you and, of course, the reproductive division. So I don't mess this up, the reproductive psychiatry division at Meridian. But when I was doing a little bit of investigation work, because I like to do that before we meet with our people, I saw that you are a board certified psychiatrist and you studied at Northwestern. You studied women's reproductive health. Why and how did you get into that?
Yeah, that's a really great question. So for people who don't maybe know the path of like becoming a psychiatrist, like went to college, medical school, and then really liked mental health and psychiatry, and so pursued a residency in general psychiatry, which is where I was at Northwestern. And then while I was a resident, which is like a 4-year program, one of the electives I had done was with Dr. Crystal Clark, who is kind of a world-renowned expert in reproductive mental health and women's wellness and women's mental health, and just truly fell in love with what she does. It's kind of remarkable to see how impactful you can be by supporting, validating, and offering treatment options, right, during some of these reproductive phases, whether that's through the premenstrual time, certainly through the peripartum, so pregnancy and postpartum, and through perimenopause and post. And so I really just was so impressed by the development of relationships you can have with your patients. And decided to do the fellowship in it. And I'm so, so thankful for that.
Well, so are we, by the way.
Yeah, I was going to say, and so are all of us gals who have all of these things that go on that really we have no idea what is happening and why. So get ready. We have questions.
It's so true. Well, it's so true because I'm kind of jumping into perimenopause and menopause. I don't even know where I fall on like the timeline, especially just having had a baby. Well, not just having had, almost a year and a half ago. But I feel like there's there's a stigma to perimenopause and menopause. You hear hot flashes, you hear about hot flashes, you hear about like lowered libido. You hear about it being a horrible time in a woman's life.
Vaginal dryness.
You hear about all these things.
Yeah.
Also, you hear about, women going crazy during menopause, which I hate hearing that because it's almost like we're waiting for that moment in life to go crazy, go through menopause, and then come back around again.
Well, I feel like it's almost like you lead with fear. Like, yes. It's scary because that's what it sounds like. It sounds like it's no fun and scary.
Aparna, what have you noticed about like patients or just this reproductive psychiatry as a whole? Now that there is a division at Meridian, what have you noticed about women coming and seeking help for their mental health?
I really, truly love that question. It's interesting. When I first started at Meridian, I was one of the only especially new psychiatrists who was specialized in this field. And so in a great way, had a lot of access and openings and availability to see women through different reproductive phases. And a lot of the people that started working with me, it was kind of by luck, right? Like they had just heard about Meridian as a practice and, were referred. And then when they met with our intake, our intake was like, oh, are you considering getting pregnant, or are you postpartum, or, they'll ask some of those screening questions for reproductive mental health. And a lot of the people would be like, oh, actually, yeah, I didn't even know that that was a specialized field or something to consider. But since then, I do feel like it's like the community with like women or people going through different reproductive phases is really, really, really beautiful. And like people are wanting to share, and so honestly, even in just like the few years that I've been and attending at Meridian, like things have shifted so much in terms of people telling their friends, telling their therapists. Like it's just amazing, like how much even just like one person can have an impact on like a community. And so then to have expanded into this huge division, like I personally am seeing so many more women now that are now like new patients to me come in being like, I'm seeking their services. Like I had heard about this, and I think that's awesome. And I think there's more and more conversation about this, certainly on social media, which does not hurt. But yeah, it does feel like a lot less stigmatized. And I have always been a really big believer that there's all these tropes about women, about being crazy or being irritable or being neurotic and
anxious, all of it.
Yes. And I think that a lot of that comes from like a very misguided lack of understanding of, first of all, who we are, but also like the amount of multiple different hormonal like cycles and phases we go through. Not to mention just like, I think unfortunately there's still a lot of gender stereotype and tradition and like the mental load and like what we have to carry. And so it's a great population to work in. And I think a lot of women feel seen. Like I think a lot of people are like, I just assumed I needed to feel this way. I had to feel this bad. Like, and that's just not true. So.
You touched on something that we wanted to ask you about a little bit, because we know about the hormonal shifts that we have as like young women. You get your period, and then depending on if you do have a child, you go through that shift of prenatal and then postpartum, and then of course being pregnant, and then postpartum, and then you go through perimenopause and then menopause. Is that it, or is there something else that we don't know about?
No, those are like the three.
Those are like the three big
defined,
ones?
Yeah.
Okay, good. I actually was a little nervous that there might be more that we don't know about.
I know. I was like, what, is there one that we really haven't heard of? Please, no.
And in regards to the latter two, when do women usually, or is it so diverse that it's hard to pinpoint an age, do women start experiencing perimenopause and menopause symptoms, signs? And also, this is a loaded question, but what the hell is the difference between perimenopause and menopause?
Yeah, no, that's a really great question. So average age for perimenopause to start presenting is usually like mid-40s. Obviously,
from perimenopause, mid-40s.
For perimenopause,
so Michelle, that's you. That's you, Michelle.
Yeah, just moments away from turning 46.
Yeah, you are like our target demographic.
Can I ask you a question? What are we like? When you say start presenting itself? How does perimenopause present itself?
Yeah, so that's a really good question. So usually, the first symptom tends to be irregular menses or irregular, cycles. And so essentially, like for maybe several months, you may not have a period, but then it'll return for a couple months, and then again go. And what perimenopause is essentially like our body is now transitioning to like the follicles in our ovaries like no longer producing or releasing eggs, so that like we're no longer able to be fertile, essentially. And so the reason why perimenopause can be so disruptive to like our mind and body is because obviously that is a really big hormonal shift, where, eggs, a big part of like that whole process is producing hormones like estrogen and progesterone. And so like as you have a declining amount of hormones, then that sends a really interesting feedback loop to an area in the brain that like is like trying to actually get your body to produce more estrogen, but your body is like transitioning to a new phase.
That's very interesting. Okay.
And that can last 3 to 5 years. I think that is the hard part.
Okay. So are you saying that it seems like the real tumultuous part of this menopause that we know, because perimenopause to me is a newer term, is perimenopause actually the struggle? And then you kind of ride. Okay. I'm just trying to get this timeline right.
And a lot of evidence supports that. A lot of clinicians agree with that. So the harder part there's like a 3-part stage when we think of menopause. It's perimenopause, menopause, and then postmenopause. The hardest part is that perimenopause. So it's that transition.
See, that's such a huge misconception.
Yeah, that's really good to know. It's like once you get over that hump, it's kind of like smooth sailing.
I'm in menopause, baby.
I'm in menopause, baby.
It's supposed to be. I mean, of course, like occasionally, some people may have symptoms, but perimenopause is the hardest part. And it can last several years. And what menopause is defined as like 12 months of not having a menses, right? And so that's when
that's what that is.
You're considered. Yeah. Okay. And then like once you've gotten through that year, like that's when you're considered postmenopause.
And I've been doing a lot of reading and like seeing like TikToks about people being like, after menopause, I'm like a new woman.
Feel like a new life, lease on life.
Yeah, it kind of sounds like the same, but totally different. But like the postpartum phase, like for me, it took like, I jokingly, kind of not jokingly said like 13 to 14 months. And I felt like I got my groove back. Energy, some looks, some, regularity in my mind and my life. Okay. So then after menopause, now a couple of those other symptoms I wanted to ask you about, like, again, we bring up the hot flashes because you hear about that. I've been hearing about hot flashes since I was able to hear.
We've heard about hot flashes since our parents would go and have thermostat wars, and my mom would turn it down and my dad would turn it up because we were all like this and she was doing this.
Yes. Yeah. So does that present more or less in perimenopause?
Yeah. So right. So like the first symptom of perimenopause tends to be that irregularity in menses, but then other really common symptoms are things like hot flashes, night sweats, irritability, mood or anxiety disruption.
Got it.
Changes in sleep or insomnia are probably like the most common symptoms. And I would say a lot of those tend to come in perimenopause, which can be several years. So that's a long time.
That is a long time. How do you and your colleagues help treat women who are going through perimenopause? And when it comes to like mental health, where does that play a role? I know you just mentioned like anxiety and disruptive sleeping and whatnot.
Yeah, that's a great question. So, specifically from a mental health perspective, the perimenopausal period is a higher risk period for disruption to mood, so depression as well as anxiety, which can impact irritability. And so that's why those are very common potential symptoms that can happen. And I do like for people to be aware of that, because often this is happening typically when somebody is maybe like in a different part of their life in a way that like they've accomplished a lot, right? And like had children and may have done a lot of their career. And so it can feel very disruptive. And I've seen really, really high functioning women who had to take time off from work just from like the level of impairment they were experiencing. And so, what we can do is certainly like help diagnose or even just validate some of those symptoms and provide some, counseling around that. And then from a treatment perspective, like pretty standard antidepressants like SSRIs have been well studied and certainly recommended. I will say, in my experience, I think that like for some people, things like SSRIs or just working with a psychiatrist is adequate.
Can you explain SSRIs? Because I've heard it a lot. Yeah. Go ahead, you take it away.
No, I apologize.
No, don't be. Because I've heard people talk about it. I'm like, I've tried to learn, but you are here to educate all of us.
No.
Please.
So when we think about treating depression and anxiety, the gold standard of treatment and like the general population are called SSRIs, which stands for selective serotonin reuptake inhibitors.
Got it.
So essentially what these medications do is they keep serotonin alive longer in like the synecdoche clefts. And we have seen that it seems to be a relationship between serotonin as well as like regulation of mood and anxiety. And so it's a pretty standard treatment used. But we've studied it also very much in a lot of reproductive phases. So we've actually studied it in treatment for like PMDD, which is like premenstrual dysphoric disorder. We studied it a lot in the peripartum, so like through a pregnancy and postpartum. And then we've actually studied it a decent amount as well in like perimenopause. And so, there's a lot of questions about like why these phases may impact mood and anxiety. And, there is some thought that like the estrogen actually is a really important factor to maintaining like serotonin levels and norepinephrine levels. And so as that is declining, particularly through like perimenopause, like that is like one of many theories that's postulated as to why like that is such a disruptive time to our mood and our anxiety. And so that's why like SSRIs are considered like part of a treatment for that. And there's, I always tell people this, like, that's the gold standard or like maybe where we would start, but there's some people that don't benefit from SSRIs. Like we tried and it doesn't work. And so there's other classes of antidepressants. So, I always am really clear to say like, you're not pigeonholed to like one med or one class of meds, but it's hard to kind of get through everything obviously in like a talk, but
absolutely. But that helps me understand that more, especially about the blocking and the serotonin. Thank you for that.
Yeah. Is the idea that as the body like navigates the process, let's say the perimenopause, menopause phase, that, and I imagine, like you said, it's not a one size fits all solution. Everybody needs or requires a different form of treatment. But is the idea that the like body will actually level off when everything is kind of run its course? And then is medication treatment something that is long term? Is it more short term? Does it depend?
Yeah, temporary. Is it just through perimenopause? Excellent question.
That's such a good question. I personally think, if someone benefits from medication, likely to continue it through like that perimenopause phase, right? Like as we're going through the adjustment and even maybe through like parts of just achieving menopause. I think it depends on someone's history. Like if someone really doesn't have a strong history with like generalized anxiety or recurrent episodes of depression, it's like very reasonable to come off of medication kind of once we've gone through the transition. And I actually bring that a lot up with patients that I meet during pregnancy and postpartum, because understandably that is like a really, really hard time. It's a vulnerable time from like a biologic and hormonal perspective. It's a huge transition. And I meet a lot of people who are understandably intimidated to meet someone like me because they're just like, I've never been on meds. I don't want to be on this forever. And, like, what are the possibilities? And I always say like, if we start meds and we do well, like typically a recommendation is to stay on it about a year postpartum, because clinically, like that's what we really think about as postpartum. And then it just depends after that, right? Like, I think it's interesting. I do think like these different phases, whether it's the PMDD, like that premenstrual time, the peripartum or perimenopause, like it brings people to care for different reasons. But it's kind of amazing to see like when you work with some individuals, like people will just say, I was kind of withstanding some of these hard symptoms just because I could. And like, that was just like how I dealt to cope with it. And being on medication has really unlocked like an ability in me to have more capacity, more patience,
better
sleep better,
life.
have better relationships. Yeah. And like, I don't think I realized how much this was impacting me. And the reason I came to care in like these times was because it was just especially a vulnerable time. Right. And like, especially when you have young kids, like everything is constricted. And so it's like actually really difficult to engage in coping skills. Like, you can't just go on a run whenever you want, like, right. Like things that like you may have done historically.
Absolutely.
And I have a lot of patients who certainly come to me. I would say the majority of people who are like new to being on medications, well, that's their number one question is like, when can I come off of this? And I'm always like, we will do whatever you want. But like, typically, like if you're doing well, like let's try your postpartum, in that phase. But I'll tell people, I would say like a majority of those patients, once we get to a year postpartum, like how they feel and they end up staying on medications, but that's completely their choice.
Okay. I would totally have the same question, or I would probably make the same statement. Like, let's fix this, but when can I come off at the same time? That's just how, but I can understand too, if you're thriving and you're feeling good and it's helping and amplifying your mental health, then why not think of it as a possibility to continue that? So we covered perimenopause a little bit. So once you get through this like mid 40s, is menopause considered around like the year, like 50 years of age?
Okay. Yeah, like that's the average age of when people tend to achieve menopause. Yeah.
All right. And that is when you do a full year without your cycle, and then you are your best self afterwards. If you're feeling
hopefully,
Is there any truth to when people say like, well, you can pay attention to your mom's history and track yourself? Is there any truth to like tracking your own cycle to how your mom's cycle went? Does that matter? Does that have any effect just on how you might? I'm just saying because like Lauren, our sisters, our mom seemed like an average menopause age
like mid-40s,
lady.
Yeah, for sure.
I think so. I don't know if that's been formally studied. Unfortunately, like of these 3 stages, perimenopause has received the least attention, I would say, from like a research perspective. I think in time that will change.
Perimenopause has
received the least.
But that's what's crazy is that based on what you said at the very beginning of this conversation is that is the most tumultuous time of menopause, and it gets the least.
Sorry. I guess I meant like the menopause, like comparing like premenstrual pregnancy and menopause. Like menopause probably has gotten the least amount of focus. So I don't know if they've like actually identified like looking at family history. But as someone who has like worked with a lot of patients, I have seen that track. So I wouldn't be entirely surprised.
I had a question in regards to treatment. And also, I think you said something about counseling. If someone came, say I came there for even, I would consider coming for postpartum. I know I'm a bit out of that, but we'll talk about that in a little bit. But if, do you pair counseling with treatment at Meridian, or is it all psychiatry?
Yeah, that's a great question. We have both.
Great.
So yes, we have so Meridian, just for people to know, is a pretty large practice. We have like 50 plus total providers. And it's pretty evenly split between like people that are therapists and provide like talk therapy or support, and then people that are prescribers. So mostly psychiatrists who can provide medication to kind of help supplement treatment. And so within our reproductive psychiatry division, we equivalently have like a pretty mixed group, but there's about 20 plus of us. And I would say it's about half and half.
Just for the reproductive?
Just for reproductive. Yeah. And it's
That's phenomenal.
Yeah. It's really, really great. We're very lucky.
You are.
Really great.
Same with the women who are listening to this podcast, or anyone that even comes by the fact that there's a whole division dedicated to women's mental health and wellness at Meridian is also mind-blowing in a wonderful way. Because my thought here, yes, what, Michelle?
Well, I was just going to say, because how many times have I sought treatment and needed medication and was going to seek therapy. And, it was sort of like, you feel like there's a little bit of a disjointment there. The opportunity to be able to connect with all of these providers under one space is like actually like a dream come true.
It is. But the other thing that I struggle with is how, like, after I had Luna, so that was in July, you get these like kind of really, I don't know, the lack for better terms, like shitty follow-up appointments, like with your doctor. It's a quick 2-weeker check-in, how you doing? And then a 6-week check-in, how you doing? And I'm like, I can't even answer that question.
Laughable.
It is. And I can't even,
ridiculous.
It's hard to even answer that question. How are you doing? You're in the thick of it.
I don't know.
Why aren't there like those 3-month, checkups? Because Aparna, and we're going to switch gears a little bit if that's okay. Michelle, did you have any other questions about perimenopause or menopause? Because I thought maybe we can shift gears a little bit.
Yeah, no, let's shift.
And we can always go back if we think of something.
There's no rules here. Okay. This is our show. Okay. We can do whatever we want.
We'll fire ourselves if we have to. So my question, because Aparna, when we talked on the phone like a few months ago about like postpartum, you brought up postpartum OCD, and I was like, my mind was blown again, because after I had Luna, of course I know postpartum depression. And then I was struggling with some stuff. And then it was addressed that probably it's postpartum anxiety. I'm like, oh my God, didn't even know that was a thing. And Michelle, I don't even know if you knew that.
No. And I also reflected on my thoughts postpartum, and they were anxious, intrusive thoughts. They were there, but no one didn't talk. I just kind of like suffered alone.
You suffered in silence. Yeah.
I was just trying to keep 2 babies alive at the same time.
And that's a lot. And then after that, Aparna, I was telling you about like the intrusive thoughts that I was having and some of the struggles I had postpartum. And you were like, oh, maybe and you didn't diagnose me, but you brought up postpartum OCD. Again, mind blown.
Who knew?
No one freaking tells us anything. And I'm so grateful you are here to tell us a little bit more about this. I don't know if it's even easy to do this, but is there any way you can differentiate the 3, or how? Yeah, take it away. How does that work?
I love this question. It's like a really, really common conversation I have with the patients I work with. Because I agree. I think so. In a great way, I think there is an evolving conversation about postpartum depression, right? I do think there's a little bit more awareness that this is something to pay attention for.
Totally.
I completely agree that the screening
or the
blues, the baby,
or the lamest name that she had the baby blues. I'm like,
listen,
that's more than the blues, baby.
At least they do ask us, are you feeling okay? Like, I mean, is there, that's it. Are you wanting to hurt yourself? That's the only question.
I didn't even get that. What? I don't even know if I got that. Okay. Sorry. Go ahead.
Sorry.
Aparna.
Go ahead.
No, you're good. So, it's interesting you brought up the blues. So, because I'm happy to talk about that a little bit too. So, there's a distinction between like what we call postpartum blues and then postpartum depression. Okay. So, postpartum blues is something that can actually affect like 80% of women in the postpartum, and it's very hormonally driven. So it comes from like that huge hormone crash from delivering. And basically the first 10 to 14 days after delivery, a lot of women experience irritability, very tearful, feeling incredibly overwhelmed, like a lot of it is understandable.
All that makes sense though.
Yes. And what I do try to remind people of is even if like, let's say you actually are on treatment for depression, anxiety through your pregnancy, that doesn't mitigate risk for postpartum blues just because it's so hormonally driven.
Sure. That's and just can affect the body a lot doing of women. Its thing. Got it.
Yeah.
Okay.
Where we get really concerned about like postpartum depression or even postpartum anxiety, which I'll go on to like distinguish in a second, is really the persistence of symptoms past like 2 weeks. Clinically, postpartum can be considered up to 12 months after delivery, which I think is really valuable. I think the highest risk time for like onset of symptoms tends to be the first 3 months. But I've actually met a number of women who like they really started presenting with symptoms at 6 months postpartum or 9 months. And so I do think it's valuable for people to be aware of that, just so that you again are not like, well, this can't be postpartum. Right. Like I'm too far out. And I will say this, like, yes, clinically, like we circumscribe that postpartum period to 12 months. But as a mom myself, I'm like, motherhood, parenthood doesn't end. And like, there's just reasonably like ongoing like symptoms that we are happy to monitor and treat as you are balancing life. With a kid. But in terms of distinguishing like just what's depression versus anxiety versus OCD, depression, we tend to think of it as a cluster of multiple symptoms, typically of feeling sad, low, not getting enjoyment out of things that typically would be enjoyable for you. So like, meeting up with a friend for coffee, watching a television show, lower motivation, fatigue, disruption to appetite, whether that's like eating more or eating less, disruption to sleep. So either being like really hypersomnolent, so like sleeping a lot or sleeping less. And then in really severe cases, like feeling hopeless, having thoughts of suicide. Yeah. So like having that cluster of symptoms.
And so that's postpartum depression.
Yep.
Yes. That would be like typically what we would see in a postpartum depression.
That's a lot. That's so sad.
It's really sad. It's so super sad, very treatable, but
that's
something to kind
of. That's amazing news.
Yep, that's great. You know what? Because it is a very sometimes there's those feelings of hopelessness, or like, am I going to feel this way forever? Okay, so then,
and guilt for feeling that way. You just had a baby. You should be so excited and happy, but you don't, and you're not feeling. There's a million things.
Yeah, there's a million.
And I like that you brought up the word guilt because in postpartum in specific, we tend to see guilt actually as a very common symptom in depression and shame. Like we see a lot of women present with shame of like not being a good enough mom, which is like very sad. So,
and that's just going to drive that depression. I mean, if you can't get out of your own way and those thoughts are leading.
Yeah. Anxiety wise. So anxiety is a little bit different in that what it tends to be is dread, worrying, what we call like ruminating. So just constantly like refocusing on like the same thought. In some cases, there's a term we use called catastrophizing. So it's like anytime a situation is presented to you, your mind automatically goes to like, what's the worst?
I've had like cancer 5 times since I've had my baby. Yeah.
Yes, health anxiety is a very, very common thing postpartum in particular.
I think that's a huge struggle. And I think that, and it's so real now that I've talked to some more moms, now that I am, when you talk to more about this stuff. And it is so common. I have a friend who I was kind of embarrassed to share some of my thoughts. And then she started sharing hers. I'm like, oh my God, we're going through the same fucking thing. Like, this is insane.
Yeah. Oh yeah. It's so way more common than people realize. Yeah.
It really is. So anxiety is it sounds much more fearful.
Yes. Anxiety is rooted in fear for sure. Okay. The way it tends to manifest is Insomnia is a huge one. So like if somebody is telling me I'm unable to sleep when baby is sleeping despite how tired I am because I'm either worried about
I've heard
baby
about
or
that.
checking on them, like that is a very common symptom, I would say.
I didn't have that problem.
Yeah.
Same.
Couldn't keep my eyes open.
Which is great.
This is why I was walking around.
I mean, I totally sympathize. Irritability is a really common one. So, conflict with partner, which is like a lot of these things are within the realm. And, just to be clear, I think that the another high volume question that I get a lot from patients is like, what is like permissible, like given that I'm going through this transition, and like what is pathologic? And that's probably one of my favorite questions. And, like happy to go into those details maybe a little bit after this. But, in general, I just look at functionality, right? I'm just like having conflict with your partner is a normal thing, like even when you're not pregnant or postpartum, but it's just looking at the number of times, the severity, frequency, right? Like I think a lot of people get caught up, especially in mental health, and the fact that things are not as tangible, right? Like we're not getting blood tests. And so it's not like I can like look at your blood glucose level or sugar level and like diagnose you with diabetes or something like that. I get that it's hard for people to grasp. And like we have a lot of shame, I think, around not feeling like we have mental fortitude or resilience. And so I think people confuse the fact that like you actually can have a lot of resilience and like a lot of mental fortitude, but also suffer from panic attacks, anxiety. And, like I'm actually a really big sports person, and I bring this up to a lot of my patients. I'm like, athletes coming out and talking about this, I think is the best thing that has happened for mental health, because those are people that have an amazing amount of resilience, an amazing amount of mental fortitude, that are doing hard things, that not everyone can do. Just like a lot of us do hard things that like not everyone can do. But for them to then come out and say like, I was having recurrent panic attacks and like I needed to seek treatment for that, despite the fact that like I made it to the NBA, like that's huge, right? And so I often remind people of that, and I think that helps. I can't say a ton of my patients are like sports aficionados, but like I think the concept,
like, yes, NFL.
Yeah, but I think the concept makes sense. Like I think a lot of people are like, you're right. Like, this is someone on a world stage that is like doing things that take a lot of courage and fortitude, and for them to also come out and say like, I can do this, but also have anxiety is so helpful, because I think it's so similar. Like I'll tell people, like, to me, it's like, if you had pneumonia, like I had pneumonia in college, and I couldn't take one of my finals. I was so sick. And like nobody questioned it. Like nobody was like, I can't believe you didn't have the mental fortitude to like sit down and take your final because you had pneumonia. Right. And I was like, but can you imagine if I said I had like recurrent panic attacks and that like that's why I couldn't take that final? People would have like, questions.
Yeah,
they would
have go. Yeah, exactly. Or like, right.
Aparna.
Yeah. And then it makes you feel more shameful.
Prove it.
Yeah. Exactly. But sorry. And so I really, really got on a tangent there. But yeah, so anxiety is much more fear-based. And we tend to see it related in terms of like irritability, insomnia, certainly in like really severe cases, things like panic attacks. And a lot of people tend to feel it really physically. So like chest tightness, heart racing, like feeling more nauseous, so lower appetite typically, that's typically how anxiety tends to present.
Okay.
OCD is actually distinct from anxiety, even though people reasonably feel like they're on a spectrum, but it's actually a little bit different. So, OCD stands for obsessive compulsive disorder. What that is so the obsessions part of it are intrusive thoughts. So what an intrusive thought is, like an unwanted thought or urge or impulse that kind of floods your brain, that is very, what we say, ego dystonic. So like against anything that you actually want to see or engage in. And so like in postpartum,
very interesting.
Yeah. So like unfortunately in postpartum, the most common content for intrusive thoughts is what we call aggressive content. So like accidental harm coming to baby. And so like
Aparna,
a lot of people will describe.
And I'm happy. And if everyone's cool, so I've shared it in our podcast before, but I shared those thoughts with you before in that conversation, saying that those were the kind of thoughts that I was having, which are very shame based. Like you feel so shameful. You feel scared too. Or I'll say I feel scared if those come up. They've definitely dissipated, but I actually went not that long ago, about a month, where I felt like they were almost like peaking a little bit. And I was like, what the fuck? And I was like, okay, I need to actually like call Aparna for an appointment now. And actually like get this treated.
Aparna's like,
I was honestly like getting like pretty worried about it. And it's these thoughts that are I would almost prefer just to deal with my health anxiety, which I was working on and getting treated for. And then you have these like OCD, and where I was working with and who I was working with, we did definitely refer to them as intrusive thoughts.
Yeah.
We didn't touch on OCD. I don't know why, but that's what I feel like maybe more or less what I've dealt with a lot as well. So if I'm to diagnose myself, I probably suffer from postpartum anxiety and OCD disorder.
Yeah. Which is not like uncommon to have both, and I agree. I think OCD is heavily underdiagnosed and heavily undervalued. Like, I don't think that there's a lot of conversation about it. And because there is some confusion between like what psychosis looks like and what OCD looks like, I think a lot of women are very afraid to be forthcoming about their symptoms.
I can't even tell you how on the nail you hit.
Feeling hurt?
Oh my God, because that's the thing. I remember when I shared one of my thoughts that I had with my other sister, Nicole, and I was like crying. I'm like, I feel like I'm like scared to share this with you, but I have to tell someone. I even remember when I told my husband the first time, I felt like they're going to lock me up. Like, this is not a good thing to be feeling or having this thought. So can we do two things? Because a lot of our listeners, we've got a lot of like 40-year-old new moms listening in. I know this for a fact. So I was wondering if you can, first of all, talk about why do these intrusive thoughts happen? I still can't understand why those pop in. If you can take the lead there, I'd love to learn about this.
Yes. To be fair, I don't think we have a great understanding of like just why this happens from a pathophysiological perspective. I think there's like a lot of theories. Of course, the hormone shift is like a big contributor to like why it's so disruptive to our mind and body. And that's why like pregnancy, but particularly postpartum, tends to be a very vulnerable time for either like new onset of depression, anxiety, OCD, or worsening. So like exacerbation of like maybe pre-existing, depression, anxiety, or OCD. And so, the other piece of that conversation that I wanted to say is like, so the obsessions part is the intrusive thought, but then there's also like potentially a compulsive aspect to it. So like compulsions tend to be like a repetitive behavior that people engage in to get rid of that thought, right? So like that could be avoidance things like, like if your intrusive thought is specifically like, this is sad, but like some people just have intrusive thoughts every time they're cutting, like in the kitchen.
Aparna,
of, like, baby.
So I would have intrusive thoughts, and I shared this with Lauren when I'd be walking, crossing a busy street in the city, and I would be thinking that I'm going to get struck by the next vehicle that comes when I put my
That's
foot.
a really common one. Yeah.
Oh, really?
And so people avoid, right? So like we kind of think of like, oh, there's like a strong avoidance there, but like another common intrusive thought can often be contamination related. So whether it's like concerned about just mold germs or poisons or whatever. And so like a ton of washing that is now becoming pathologic, right? There's a lot of presentations.
How do you avoid the night? But the one you said about like when people are cutting things, are people like avoiding cutting? Like
they're just avoiding cooking, right? So like I'll have people come in and they're like, well, I'm not. Yeah, same.
I'm still cooking. Like, but when when I am cutting things though, Aparna, I have these intrusive thoughts.
Yeah. And I actually think, so, a huge difference, because anxiety and OCD can often feel somewhat similar. And, a big difference I try to explain to patients is, when we think about OCD, I'd used this term earlier, it's more ego dystonic, right? So like these are thoughts that you have no desire to engage in.
But they just keep rearing their ugly head.
And they're terrifying. They actually induce
really,
anxiety.
Really
and they can
be very distressing.
Yes.
Whereas an anxiety, like from like a generalized anxiety perspective or like, postpartum anxiety perspective, even though it creates distress, like nobody likes to be anxious, to some degree, part of our brain has rationalized that like it's productive to be anxious, if that makes sense. So like when we think about anxiety, like it's like, all right, somebody with anxiety is trying to decide like, okay, how am I going to get me and my kids out the door at 8 a.m.? And so like they are going through all of the machinations in their brain of like how to optimize that, right? And that's why I say like anxiety in particular is a tough one because it's very adaptive. It helps us be successful. It helps us do hard things.
It can push you.
Yes. And so like it's what we actually call ego syntonic. It like can be helpful. However, pathologic anxiety is when we've kind of passed into a threshold where like it's clearly now interfering with sleep and functionality and conversations and patience. And, like there's a time for treatment, but like that's like the big distinction between anxiety and OCD. And then just to close out the conversation, because I brought up the term postpartum psychosis, because I know that comes up on people's minds.
I'm curious about that because I have followed several stories in the news. When they come up, I will follow them because they're just so sad. And what I see there is something failed this woman. That's how I look at it. And these are, and for our listeners, we're talking about women who have harmed their children because they were suffering from postpartum, maybe things, but also psychosis. And it's such a heartbreak when you read these comments of people that say things like, oh, she doesn't deserve to be a mother, or what a monster. I'm thinking, this poor fucking woman is sick.
Yeah,
she's
really sick.
Not being treated right, or she's not being treated, or she's not speaking up because she's scared to. And it's a horrible thing that happens. But it really, I feel like someone is like the medical, I don't know. I just feel like she's been failed. It's just a very sad situation. But I am curious about psychosis because when does one find themselves like at that point? And is it usually that like doctors can notice it themselves and they're like, okay, we need to like intervene immediately?
This is a great question. I think the hard part about postpartum psychosis is it's very rare. And so it's harder to study than even like depression or certainly anxiety or even OCD. But what it is, it tends to present in the early parts of postpartum typically. So it's usually like in the first 10 to 30 days, I would say, postpartum. And what it is a combination of multiple symptoms that can include delusional thoughts. So, paranoia that like something is actually wrong with the baby and like concern, like hyperreligiosity. There's a lot of different types of delusion. The key to psychosis that's different from OCD is that it doesn't cause distress, right? Like, I think that's like where we get concerned. If somebody's telling me like, hey, I'm having this intrusive thought and it's really bothering me, I have no desire to engage with it. Like that is a OCD spectrum, right? Whereas like if someone's telling me like, I'm concerned, there's like something off about my kid, how they look, whatever it is.
And then
I don't know, and like, I feel like I need to do this type of ritual sacrifice to save that or whatever it is.
Got it. And that's what these stories are like. Yeah.
Yeah. Like feeling really like this is the right path. Like that's my concern of like, okay, that sounds a little bit more psychotic. And like, it tends to be accompanied by a lot of other symptoms. So like a lot of disorganized thinking, possible like hallucination.
Okay.
Some like cognitive dysfunction. Yeah. Like, and so typically you would hope like we would be able to discern it. And like the thing about postpartum psychosis, it is the only presentation postpartum that does increase risk for infanticide. So unfortunately, like, killing baby. And so that is why it is the only time where it's like, it's unequivocally a time where you're like, we have to hospitalize you for your safety and for the safety of the baby so that we can get you treated quickly. Whereas like postpartum OCD, that's not the case, right? Like we don't have to hospitalize and it's mostly something you can treat in the outpatient, but understandably, so many people are afraid to talk about their symptoms because they don't want to be separated and they're not sure. And you see these really concerning things come up in the news and it can be hard.
I love that you shared that though, because I think that's what stops a lot of women from speaking up is that they are actually scared that someone's going to be like, all right, go get the straitjacket. She's having these intrusive thoughts. And it's like, actually, when we get to learn a little bit more about what happens to our mental health after we have a baby or anytime during our hormonal shifts, you're like, oh, I'm clearly suffering from some sort of something. And now that I'm a little bit more empowered with knowledge, I can reach out and feel safe in doing so and not feel like you're going to be locked up.
Yes.
And even if that is for their own safety or the safety of others, understandably, if they're suffering from psychosis and whatnot. Right. But when we have these other illnesses that we're not suffering from or experiences that we're not going to be, separated from our family from, but we can get help and start feeling better and the quality of life increases. It's like, but that's the thing. That's why I didn't say anything for a long time because I was so scared. And even the health anxiety that I was suffering from, I was super embarrassed, but also felt kind of real too. This is a real disease that I have. Now I'm going to die and my baby's going to be left alone.
Yep.
I can't even get over how much we've learned in just a 45-minute conversation about women's health, stuff that we didn't even know 45 minutes ago. I had a question in regards to how one can find. So when it comes to, I'd love to hear this actually from you, Aparna, because I feel like people struggle with finding the right provider. And that's that's what we hear a lot from. Actually, people will write into us because we'll share our therapy experiences, and someone will write in and be like, I had a therapist, I didn't like them, so I haven't gone, and I don't feel like going through the struggle bus of finding a new one.
Sure.
As a psychiatrist and a person that works with other counselors or works with counselors and psychologists, what is the best way for someone to search for a provider, going beyond just if their insurance is taken, but like finding the right human to connect with?
Yeah, I actually think this is a really important question because I do think people feel bad when they haven't found the right fit. And I actually do think fit is really important, particularly when you're doing mental health.
Same.
I have a lot of patients who, I have a good relationship with my patients, and that is a little distinct than maybe their relationship with their primary care doctor or their relationship with their cardiologist, right? And that's okay. I think every field works a little bit differently, and I do think that is actually important because I do want people to hear that and not feel bad about maybe looking around. Sometimes it may be more on the patient end of okay, maybe our expectations are a little bit out of the scope of what we can get, but not always. I think in terms of actually finding a good fit for you, that's tricky. I mean, I feel personally, just totally personally, I would do it. I would do it really on word of mouth.
Great.
Which
that's
I know
how I found
sounds
one of my
surprising.
therapists. No, that's how I found a therapist. I share one with a friend of mine.
I've always been very insistent on this for myself. I really believe in my brand individually, and of course Meridian as a practice, and really, really proud to be representing them. But I have always felt very strongly I have to represent my brand really well. And people buy into that. They respect it. And, that's how you build your practice. And, you attract patients that want to work with someone like you as well, which is nice. And so I feel honestly, a lot of my referrals for a while have truly been word of mouth, whether it was a patient told a therapist who then, or I had collaborated with a therapist and they liked me, or a patient told, a colleague or a friend or something like that. And to me, that is probably the best way to find someone that is going to be a good fit.
Michelle,
of course, sorry.
No, I was just going to say, I think that's good advice. And I also think that leans into inspiring people to talk more about what they're going through.
Yeah, and who
have conversations about what's going on with you, with your lady friends, with your tribe, with your husband, your partner, your spouse, whatever. And that will then what happens is when I always say this, I talk about everything. I probably talk too much about certain things, but what I find out is when I talk about things, I learn and I also get connected with people and stumble upon the person that is an essential game changer in my experience or one of my family members' experience. So I think that's great advice. Advice.
And what I was going to say, sorry, is
no, go ahead.
If somebody happens to meet with me first and don't have a therapist, which isn't as common, I feel I tend to get referrals from people who didn't want to be on medication, started working with a therapist, and then we're okay, I think I need to consider meds, but sometimes I really do just meet people first, and that's helpful too. Because if you got my name for whatever reason from a word of mouth, and I have therapists that I know, and yes, that can also help. But yeah, I'm a pretty big fan of word of mouth because I think people having ownership in their brand is really, really important.
It's very important. Another thing I was thinking about, and I don't know if you guys have this, but does your division have any sort of is there some sort of support group for women going through these hormonal changes?
That is such a good question. Right now, our group does not. We are actually in the process of a really cool project that I don't think I can speak to.
Okay, well,
fully,
we will stay tuned.
But we will share with you.
Okay,
yeah, we will share with you. That I think will be really, really impactful and provide a lot of education and information and support for possibly expectant parents, essentially. And that I'm really excited about. So that is to be coming. But we certainly have plans to hopefully have support groups at our own practice in the future. And there are some other perinatal practices that do have support groups that like we often will refer people to that, you know, are good like colleagues of ours. So.
And then one of the last questions in regards to the conversation here before we end up with the questions for like cozy convos, being the medical director of the reproductive psychiatry division at Meridian, I was wondering what your favorite part of the job is.
Well, I feel like I have two answers.
Please.
I think my favorite part of it is that it's helped me in terms of like building community at Meridian, within like those interested with working in like the women's wellness, reproductive mental health space. You can feel that community. I think we started the conversation out that way, that like it is nice to join a practice that has a lot of interrelationships and communication, right, between prescribers and people that provide therapy, because context is everything, right? Like, even though like I primarily prescribe medications, you know, a big aspect of what I need to do is understand like what I'm treating. And that requires a lot of conversation. And so whether that's collaboration with a therapist, of course, like getting history on my end, all of that. So I have really, really, really valued like building that community and like building the level of like relationships that we are able to have and continue to have. Honestly, my other favorite part has been doing things like this. Cool. I never in a million years thought I would like be on social media, like, you know, doing these, and it's really, really fun. Like it's hard to say it any other way. Like it's just, it's kind of wild to see, you know, like when you go through the med school track, it's a very insulated bubble that is like very almost like surgical, and you're just like doing your own thing and like training in a very rigorous academic setting. And honestly, a big part of why I left academics and like wanted to be in private practice was because I love being a doctor. Like I really like working clinically. I like seeing patients. It's my favorite thing. But to see how social media can like expand the reach, you know, is really remarkable. And it's cool to see medicine like tap into social media, because I tend to find like medicine, like we tend to be the very end of industries to like be taking on like tech and like new things, which I mean makes sense, but yeah, it's I really like this part of it.
Well, we are glad that you like it, because, and I do now that we're like catching up, because we were introduced to you as Aparna, but we and I think in our bio we already addressed you as doctor, but I mean, I'm so sorry about. Okay, good.
You guys should only call me Aparna.
Okay, well, right.
Done.
Okay, fine, deal. Okay, but you know, I wanted to say in response to what you just said, thank God that you like that part, or goddess, we say thank goddess around here, that you like coming on, you know, podcasts and spreading the good word of taking care of women's mental health, because like Michelle and I just kind of said earlier in the conversation, it's not something that's always talked about. And sometimes it's more talked about behind closed doors amongst, you know, best friends or a sister. And then it kind of stops there sometimes, unless someone hears a podcast like this and then they're, you know, alone at someone's house and a friend of theirs is sharing with them their struggles. And they say, oh my God, well, you know, I listened to this podcast, and then it kind of keeps that ball rolling. So we're super grateful that you like this part of your job, because we love having you here. Before we get your contact info and how people can reach out to you and find you, we wanted to ask you two questions we always ask any guest that joins us on Cozy Convos with the Sister Project. The first question is, if you are reading or watching anything that you think that our listeners might also be into, and it can be outside of the genre of women's mental health and whatnot.
I know, I saw this question.
But it doesn't have to be.
But it doesn't have to be.
Don't limit yourself.
Yeah, don't.
I'm definitely not doing anything like that in in the women's mental health genre, so it'd definitely be out. I was laughing at asking that question because the NBA season just started, and I was like, I
love your sports love.
Wait, you're a sports junkie, aren't you?
I'm a soccer freak. I'm obsessed with women's soccer.
And I wasn't, to be fair, I wasn't a sports fan prior to meeting my husband. Like I was like really into arts, and I still am, like love the ballet and all of that. But like, he's from Cleveland and is like a very
is that the Celtics? Who's Cleveland's NBA team?
I love
Boston.
I'm dying. I am a huge Celtics fan because I went to college in Boston. So I love that you just said that. But no, it's the Cavs, and like that's who my husband roots for.
Listen, I'm not a sports nut. This is so surprising. It's fair. I'm so surprised by this.
That question because I was like, I feel like especially when the NBA season starts, that's like what our house watch.
So you're doing
that's
NBA.
what we're doing. But I have a recommendation, which isn't going to sound amazing because it's like such a popular show. But I recently just finished Succession, and it is hands down the best show I've ever watched.
Okay,
yes. Wait, so I watched some good TV, and like that was hands down the best show I've ever watched.
Who's your favorite character in Succession?
That's so easy. Kendall Roy.
I know.
Which people don't.
No, people get mad at me when I say kind of think he's hot sometimes.
I was rooting for him the whole time. And my college roommates, we still have a thread and we still text every day. And one of my college roommates was like very concerned. She was like, wait, what? Like nobody roots for anybody on this show.
I know, right?
I know, they're so bad.
I know, but I was rooting for people too.
Can't
such
look
a
away.
Good show. I'm glad you finished it.
It's such a good show. Great character development. It's funny. Like you watch it.
Funny. The dynamic between the siblings, and I think that's what I connected with too, is just a lot of personality, big family, all that stuff. Their banter back and forth. I was like, what? They're finish a sentence, a thought, connect. What are we doing?
Well, if you like
I was just like, my favorite part too was like, they capture the I don't know, they capture the essence of like what it is to build an empire and what the pressure can be on like the next generation in a very like reasonable way. Like if they didn't reduce people to tropes, right? And like that, I really appreciated. I was like, you did a good job.
I'm so glad you watched. That's a good one. And if you like shows like that, I don't know if you've watched it, but you strike me as someone who might enjoy The Bear.
Oh, I've been hearing about this. And
okay. There you go. That's for you.
Next on the list.
Okay, that's because if you like good TV, this is good stuff. Season 2 is better than season 1, but
agreed.
Let us
they're
know.
Both good.
And then how we end every conversation here at Cozy Conversations is Michelle and I always like to share what we're doing to just kind of upkeep on our cozy, mindful well-being. And we were wondering if you are doing anything you'd like to share with us and our listeners.
Yes, I also laughed when I saw this. I have 2 answers. One is, this is the first year that my husband's friend invited me to their final fantasy basketball league.
This is this Aparna. This is like a
final, or not final fantasy, just fantasy basketball league.
So this is for basketball.
Yeah. My husband's in like a fantasy football league every year that I feel like I hate because it like ruins watching games because he's like
because they're on their phones looking at their things.
Yeah, so I never want to be part of that. But I love basketball. There's something about it that is so fun. And his friends like from college, I had met them a year ago, and I met them for a long time, but like we were talking about basketball, and then they just texted us and were like, "You want to join us?" Like, absolutely. And I'm like loving it thus far. Like it's so fun. So that one is it, but. The one I wanted to really give a shout out to because I really love this fitness channel. Her name is Body Fit by Amy. That like people may or may not be aware of her. She's amazing. I actually have found her like so many years ago, like probably back in 2018 or 2019, when she wasn't as big as she is now. But she is by far my favorite fitness expert to follow. She has a bunch of free videos on YouTube and like has a great community, and I like her because she's very psychologically minded and like how she approaches fitness. She always uses the phrase like be where you are today. She actually does a lot of prenatal and postpartum exercises and is like impregnant in a lot of her videos, which is really cool to see. And like she's just great. Like she's not there for you to be like sexy or toned, like, which I never like. Like she's just there for you to feel good and to feel strong. Yes. And I love her.
So that's Body Fit by Amy.
Yeah.
Body Fit by Amy. She's
beautiful.
Great. Yeah. Okay. In case people don't want to join like a fantasy basketball league.
Just do Body Fit by Amy instead of joining I didn't even know that there were fantasy leagues for NBA.
Lauren, there's a fantasy league for every sport.
Yeah,
literally every sport.
Really?
I think everything. She's right.
No,
it's totally fair. I had no interest in sports. Like anyone that knows me is still baffled by this, but to my husband's credit, he like really did a good job of like getting me excited about it. And then like the way my brain works is like the minute I'm like my interest is piqued, I want to be the expert. So then I started like researching and like following like ESPN, like all of these things. Because I like to compete. And so
you take it to the next level.
Aparna, I want to challenge you to like take a little bit of a peek into the women's soccer world. They are so awesome and so fun to follow.
I'm with you. This has been brewing. I'm currently watching the Beckham documentary, which is great, which I know is not women's soccer, but like it's really great.
Amazing.
Yeah. But like women's soccer has been something I'm so proud of because like I feel like women's sports that I follow the most are like gymnastics and ice skating, but the women's soccer team has been on my mind, and they're doing amazing things.
They're doing amazing.
Women in the sport. And I guess women's tennis too. I love them. But
and they're just fun to watch. And they're everything aside off the field, their style, their swagger, their store, everything.
They really are
like
they're like hot.
They're movie stars, but
they are. They're
ballers.
They are ballers.
I mean, I watched them in the World Cup, but I'm with you. I think I need to like
don't follow some. I'll share some handles that you need to follow on Instagram. That will get you in hook, line, and sinker. Yeah, for sure.
Yeah.
Oh my God, I love it. Aparna, thank you so much for joining us this afternoon. We know that we can find Meridian at meridianpsychiatricpartners.com. We're going to link your bio straight to that so people can find you there. And they can also find you on Instagram. We will have everything in the show notes. Is there any other thing or way that we can tell people to find you specifically?
Yeah, we're also on Facebook. So if people prefer that platform, they can follow us there too.
Awesome. This was an incredible conversation. I've learned so much and I'm eager to learn so much more. So hopefully this is not the last time that we see you on Cozy Convos. This was awesome. Thank you so much for joining us, Aparna. And as always, listeners, you know what to do.
Stay cozy, everybody.
Thank you for joining us for today's Cozy Conversation. For more of The Sister Project, check us out on Instagram at The Sister Proj and our website, www.thesisterprojectblog.com. Don't forget to subscribe to our podcast and maybe even drop us a review. Until next time, stay cozy.